to the said round, and you can take it away.
Right. Everybody hear me okay? We're going to try to share my screen and we'll see what happens here. It's been a little while since I've done this. Full disclosure before we get started is I've been on call this week and I'm running on about 3 hours of sleep. And so that ain't great. So I'm kind of in the phase of extreme fatigue versus a little delirious versus hypomanic. So if I say anything off kilter, please don't judge me too much. All right. Is it coming through okay under normal view or?
Yeah, it looks great. I'm here for you. If I could, do this for you, I would.
Thank you. Thank you. It's fine. It's fine. So I appreciate everybody being here. So cannabis and concerns, what's the big deal with THC? So I know Tony a few months ago gave a really good lecture more about specifically the THC group, how it relates to, treatment, how we do it. This lecture, I wanted to be a little bit more on just basics of marijuana and some of the concerns that I share and colleagues have shared when we've discussed it. We'll see how much we can get through. I purposely made this slightly longer. We'll try to cover as much as we can, leave some time for questions, and you all will have access to the slides. And if you want to do a little bit of research on your own and go from there. All right, so that's where we work, but we don't really work there. We have the much smaller building that's not as fancy. That's the one that was on 60 Minutes, so everybody knows. I like this quote from Warren Buffett. What we learn from history is that people don't learn from history. People have said that quote in different ways before. I don't have too many like fun things in this lecture like I sometimes do, but I do like that quote. So I think it's good to think about past experiences we've had, certainly in this country clinically, but also see what's happened in other places and learn from them too. So we tend to pretend like there's always something new under the sun when the reality is a lot of these things have, it kind of goes through phases of acceptance and things that aren't so accepted. What's looked at is like normal medicine. What's not looked at so much is medicine and standards of care, but we'll move on. So disclosures are, I don't really have any disclosures. I'm not connected with any entities. I have no commercial or pharmaceutical ties. I do sometimes pick fights with pharmaceuticals or attempted medical THC conference sponsors. So we had a run a couple years ago where medicinal marijuana was actually trying to sponsor our like professional MD meetings and DO meetings and stuff. And thankfully we put the kibosh on that. So the bottom line is I don't work for any drug company, not influenced by the big cannabis industry. I've actually had some nice threats at times by various people on either side, so that's always interesting. I mainly work in the IOP with Laura Lander, and I also serve as the president of the West Virginia Society of Addiction Medicine. I don't know if anybody's going to ASAM in about a month from now in Dallas, but I'll be there. So let's take a pause for which cause. So any discussion on marijuana cannabis inevitably elicits strong emotions. I'm not really trying to overtly offend anyone, but definitely trying to have everybody examine themselves. Whether you're really in favor of it or super opposed, it's always a good idea to ask, why do we feel such ways? Is it because of experiences we had, when we were kids, things we've seen in patients, things we've heard about on the news, science, or what is it that leads us to believe the things that we do in medicine? I'd say fundamentally, nobody wants to see our patients, especially if we have younger patients or children, suffer from any ailment if it can be avoided. And I just challenge everyone here to keep an open mind on the subject. It gets a little interesting. I don't think we'll have anybody that's really necessarily where this is as controversial a group to talk to, but it can certainly stir up some emotions. Might be interesting to watch the YouTube page and see how the comments are afterwards. So we'll see. So the main objectives of this are to describe cannabis, endocannabinoids, and how they work. So just understanding a little bit for those of us who are in medical school. I never got a single lecture on endocannabinoid system, so it's kind of an interesting subject. I think that it's kind of a part of knowledge that many people lack just because largely untaught. We're going to discuss the psychiatric burden of use. That's really what concerns me, is how it affects people with their mental health. Identify concerns with the medicalization of marijuana, and provide some harm reduction strategies. So I think it's kind of interesting getting to a place of acceptance where we might not necessarily be able to have people completely stop use, but what are ways we can counsel people to maybe slightly safer use? And my objective is to be informative, open, and honest, and to limit filler words. So I'll try not to say and like and things of that nature. But again, I'm running on about 3 hours of sleep, so we'll see what happens. Okay, so what exactly is it? What already exists in our bodies? What purpose does it serve? So a little lesson. So what are the elements of the cannabis plant itself? It's a very complex alkaloid mixture of lots of chemicals. So we call them phytochemicals. That means plant chemicals, so phytochemicals. There's greater than 100 identified cannabinoids present, and that includes things like delta 9, which we think about, delta 9 tetrahydrocannabinol, which is THC, we usually refer to, and that's THC. And then cannabidiol, which is CBD. There you go, cannabidiol. The medicinal effects were first described in 1963, so people were using this well before we had any understanding of what was happening in the body. And what happened was this Israeli scientist injected THC into aggressive rhesus monkeys, which afterwards they became calm and sedated. So there was something there, but they didn't really understand, okay, we're giving this exogenous chemical, what's it doing in the body of the animal? So the ECS system, endocannabinoid system, there is 2 receptors that are found in the body. One is cannabinoid receptor type 1 or CB1. This is complicated, but it's a presynaptic receptor, modulates neurotransmitter release. It's the most common G-coupled protein receptor in the adult brain, which might not mean much to everybody, but it's found throughout the central nervous system. So it's in areas like the cortex, which basically makes human beings, hippocampus, where your memory is at, basal ganglia, which is where movement is found, cerebellum, which keeps us balanced, and how you fail a field sobriety test, spinal cord, we all know about that, medulla, breathing centers, nucleus accumbens, that's the reward center of the brain. So that's what when we think of addiction, there are receptors for the endocannabinoids in there. Cannabinoid type receptor type 2, CB2. This is more located throughout the body and linked generally to the immune system. So you find it in your spleen, you find it in white blood cells, which is pretty wild. It's implicated in a wide variety of immunomodulatory functions, including immune suppression, basically cells killing themselves, which is apoptosis, and cell migration. It also plays a role in inflammatory responses in pain, and you can see why people would perhaps use cannabinoids to treat their pain, because they're receptors that are implicated with pain. It's also present in reproductive organs, which is not well understood. So the idea is with CB1, it's mainly in the brain, central nervous system, and spinal cord, whereas CB2 is basically throughout the body in different areas. But you can see most areas of the body are affected by this. So we historically did not understand very much about the endocannabinoid system. The reality is it's all throughout the body. It's implicated in many ways. So it's clearly there's something there, and it's clearly important, but it's not really been well understood. So a little bit more into it. There's 2 primary endogenous endocannabinoid molecules. So endogenous means it's coming from the body. So the 2 that we see are anandamide, which I've been practicing this, but we'll see how it goes, and arachidonyl ethylenamide. Ethanolamide. There you go. And this was the first one identified. So it wasn't until 1992 that this was actually identified. So we had knowledge that if you inject monkeys as of the mid-60s, it would cause things to happen, but we didn't understand what receptors it was going for, or if we in our body already had molecules that looked like THC, basically. This is named after the Sanskrit word for supreme joy. It's a partial agonist of those brain receptors and the peripheral receptors, again, partial agonist. The other one is 2-arachidonyl glycerol. 2-AG. So we usually say anandamide and 2-AG. This is the second one identified, and it wasn't until 94, 95. It's found in higher concentrations in the brain than anandamide, and it's actually a full agonist of the receptors, so acting a little different. You could almost think of anandamide as a buprenorphine, and 2-AG as being more like methadone. They're both ultimately present in very small amounts in the body. So our bodies have these chemicals that exist, just like our bodies have endogenous opioids. So small amounts of opioids that are released. We have small amounts of cannabinoids that are released in our brain. So this is much less, though, than when you ingest exogenous cannabinoids or phytocannabinoids. Just like we would have very small amounts of opioids in our brain, but when you ingest fentanyl, it overwhelms the system. Okay. So a little bit in terms of apologies for what a plant-derived cannabinoid versus a brain cannabinoid looks like. This is THC, phytocannabinoids, so coming from a plant, whereas anandamide, this is what's in our brain. So these don't look all that similar on the chemical structure, but when they start wrapping around and interacting with water, they confuse the receptors, basically. So our brain cannot really tell much of a difference between this, which should be there, and this, which people are ingesting through the use of marijuana. So I hope I haven't lost too many people yet, but we'll see. All right, so what's the mechanism of action on memory? This is interesting. So these endogenous cannabinoids are the ones that we have in our brain, anandamide and 2-AG. They serve as these what we call retrograde transmitters, which is really complicated stuff. So we'll have a little diagram to explain it, but these are actually postsynaptic neurons that we usually think of one neuron releasing, like talking to the other in the brain. So really, as you say dopamine, it tells the other cell to do something, get excited or calm down. Think of cannabinoids as actually the opposite. So it's the cell, the other cell, receiving the information and talking back to the one that sent the first word to it. So it's a little bit different way to think about retrograde instead of just going forward. It's actually a signal back. So the idea is that it targets presynaptic receptors, modulating neuronal activity. So when we're talking about the brain, again, we're talking about the central receptor, CB1. So it suppresses the release of inhibitory neurotransmitter GABA, which enhances phasic burst firing of dopamine in the ventral tegmental areas. So these are things that we talk about in other areas of addiction, like GABA, which is basically gabapentin, or pregabalin, or what Xanax works on, or Valium. Dopamine, we always blame dopamine for just about everything, but you can see it's not simply activating this endocannabinoid system. It also affects other neurotransmitters in the brain. Okay. The other thing is it enhances the activity of NMDA receptors, which increases release of excitatory and potentially neurotoxic neurotransmitter glutamate in the hippocampus. So glutamate is an overexcitatory, basically, neurotransmitter that causes problems. When you're using tremendous amounts of, say, methamphetamines or cocaine, glutamate becomes one of the most damaging things to the brain. Specifically, it's going towards the hippocampus, which is where a lot of short-term memory is stored. Okay, so the net results of it, this is kind of interesting. So you've kind of checked out or not. So endocannabinoids, so the normal ones we have in our brain, are actually released on demand to suppress unwanted or unnecessary memories. So, for example, if you have something traumatic happen to you, your brain might say, all right, we're going to release a bunch of these endocannabinoids to basically help you forget about what's happened, what's just happened. Or let's say you only need to very briefly remember a number to call, to call a pharmacy, and it's not something you really want to commit to long-term memory. It's just something you want to store away for 2 minutes or whatever. That's another role that endocannabinoids plays. It basically hit Control-Alt-Delete, go in, delete some things that you don't need to clear up your memory. So you can start to see is how maybe when we begin fooling around with the system a little bit, it might just have an effect on memory. Okay. So this is the way it works. So CB1 or CB2 receptors. So this is the presynaptic neuron releasing things like, let's say, dopamine gets released. This is the postsynaptic, attaches to the receptors, and then actually the endocannabinoids go back and talk to the original cell and say, all right, cut it off, or maybe release a little bit more. So it's a negative feedback modulator to the neurotransmission at the synaptic cleft. So we usually think of it going this way, and something like an SSRI actually would keep more of these things around. If, say, it's serotonin, with cannabinoids, endocannabinoids, they go back and they tell the cell to do things. So it's pretty interesting when you think about it. All right, so what does this all mean? Again, if you're not a neuroscientist or a biochemist or whatever, so what does this all mean? It means this cannabinoid system is part of our mood and memory regulatory system. So these receptors in our brain are intended for what exists in our brain, which is anandamide and 2-AG. So we have these receptors and they're meant to be occupied by these normal neurotransmitters that exist for our good. So they regulate the balance between excitatory and inhibitory neuronal activity to achieve homeostasis. So they are part of the system that basically makes everything normal. All right. With the CB2 receptors, they work more in the immune system and on pain in less clear ways, so not understood as much. What we do know is that exposure to external cannabinoids during, especially adolescence, which is mainly what I'm going to focus on, but this disrupts glutamate specifically, which plays a role in synaptic pruning of the prefrontal cortex. And basically, it disrupts normal brain development. So by interfering with the normal system, it will alter brain chemistry and the ways our brains develop, especially in youth. So why do people use cannabis? I've kind of pushed it more as a negative. We'll talk a little bit more, but why do people use just in general? So people use because it helps treat their anxiety. So a lot of times when I'm talking to patients, they say, well, I'm pretty anxious, and using calms that. People have pain. So there is a role that cannabinoids play with pain. As a matter of fact, we have pain consults here, and they will use things like the actual FDA prescribed Marinol, which is pure THC, to help augment pain regimens. So there is something to be said for that. People will use it to treat nausea and anorexia. So they can't eat, you're not hungry, people will eat it because it does increase your appetite, working the brain. I hear people say all the time, and I use it to control my ADHD symptoms. Some people use because they want to experiment with substances, and they look at cannabinoids, marijuana, as a safer alternative than, say, alcohol or using other drugs. We can argue whether it is or not. So it's an alternative to, say, something like alcohol. And lastly, of course, let's be frank, people like to get high, and marijuana makes people high, depending on how much you use, what method of intake you use. It can make you high. The counter argument with these are, instead of helping with anxiety, generally speaking, it rarely helps long term with anxiety. So what we tend to see is people that chronically use it for anxiety, their anxiety level actually ends up being higher than when it started with chronic use. In terms of pain, it seems to be better overall for more like chronic and especially cancer pain. It's not I certainly don't want anyone to leave here thinking that there's no place for this stuff, because there certainly is. But it's not meant to be it's not necessarily a great option if someone's having surgery, right? They give a bunch of cannabinoids and they expect to treat the pain. In terms of nausea and anorexia, it usually can help with people who have problems eating. I will say that with chronic use, some people develop treatment-resistant nausea related to their cannabis use. So that's something to keep in mind. In terms of ADHD, it generally worsens your concentration. It may perhaps quiet your mind a little bit, but also makes it difficult to concentrate. So I wouldn't necessarily say it's the best treatment for ADHD, certainly. In terms of experimenting with substances, the reality is that in terms of first use, 70% plus of people, their first use of any drug is cannabinoids. So we talk about it as a gateway drug, a gateway in a sense of most people who we treat, I would say, don't immediately go from never touching a drug to using fentanyl. It's more of a progression from say we've experimented with THC. We work towards pain pills, and we go to things like fentanyl. Now, with that being said, not everybody that uses THC goes on to use other substances, but it's kind of rare to meet folks in treatment that did not first start with cannabinoids. So it's a gateway for some, but not for all. It's certainly an alternative to alcohol and other drugs, especially if you're trying to get intoxicated. But the safety of use really varies depending on factors. I often hear as an argument, would you rather spend time around somebody that's drunk, or would you rather spend time with somebody that's high on marijuana? It depends. If that person's also psychotic on marijuana, I'd probably rather be with a drunk person. It just depends person to person. So what are the physical effects and signs of cannabis use? There's many of them, but some things to kind of take note of. I think largely in medicine, at least what I've seen, perception is outside of addiction is it's not always really asked that much about use, or it's just assumed that everybody uses and not the potential ramifications to it. But smoking or vaping cannabis can certainly lead to bronchitis and other lung conditions. There is this growing body of evidence that actually smoking cannabis will worsen COPD, and this is actually greater than cigarette smoking alone. So more and more things coming out that it's actually worse. So you can the combination is probably the worst of anything, mixing cigarette smoking with cannabinoids, but smoking marijuana is not great for you. Smoking anything is obviously not great for you, and it can lead to COPD. But it's for years it was almost the industry would say, "Oh no, it won't cause COPD or couldn't cause lung cancer." That's nonsense. There are actually potential carcinogenic effects on testicles, so it's kind of interesting. You can get testicular cancer, which seems to be related to cannabinoids. Keep in mind, though, not everybody who uses marijuana, just like not everybody who uses alcohol, is addicted to it or qualifies as an SUD, substance use disorder. The cannabis use disorder rates are actually estimated at being about 10 to 30% of active, which is last month, cannabis users. And these rates are not all that dissimilar to folks that use alcohol. So not everybody that uses has a problem or meets all the criteria that we have, but the reality is many people do have problems with it. Briefly, wanted to talk about cannabis withdrawal. So this is from the DSM-5 TR, of course, now. But the reality is there is withdrawal symptoms from it. So this is something you will see when people are admitted to the hospital or rehab. So it's typically when people have been using heavy amounts or for a prolonged period of time. And you'll see 3 or more of the signs and symptoms. This is the diagnosed cannabis withdrawal. So irritability, anger, or aggression is something that comes about with cannabis withdrawal. Nervousness or anxiety. Again, we mentioned people will use to treat their anxiety. The unfortunate thing is when they stop using, their anxiety tends to get higher at first and then kind of goes back to normal. Sleep problems, so insomnia, disturbing dreams. Decreased appetite or weight loss. That makes sense if people use it to stimulate their appetite and then they stop using it. Restlessness, depressed mood, certainly do that. And then at least one of the following physical symptoms. So abdominal pain, shakiness, tremors, sweating, fever, chills, or headache. So none of this is necessarily life-threatening, but people get very uncomfortable with cannabis withdrawal, or they can. So a little bit more into it. There's always these caveats in the DSM, but some take-home points about withdrawal. So it's a real thing, and it can be really uncomfortable. You can treat folks that have never used another drug in their life, and they're just heavily using cannabinoids, and they stop using, and they feel like crap for a couple of weeks. I actually had this happen to a friend of mine fairly recently. He's feeling a lot better now, thankfully. It can actually last longer than other substance withdrawals given the lipophilicity of cannabinoids. So they tend to linger a lot in our system. And so it takes a while for it to leach out. In some ways, that's a positive in terms of almost they taper themselves, but in other ways, for some people, it takes a long time for really them to get out of their system and to no longer have that withdrawal state. Oftentimes, we need to counsel patients that things like, say, their anxiety, which is a sign of withdrawal from cannabinoids, may appear worse at first, but then it's going to take longer for it to get better, but it will get better. So you need to really allow yourself time to have prolonged abstinence from cannabinoids to really see how you're going to feel once you're off of them. All right, a little bit in the seeking help for cannabis use. It's often difficult for people to seek help because there is this perception that cannabis is safe in everyone. It doesn't cause any problems. This is just something I've kind of put together. I think about a lot, but if you're somebody that has dubious ethics, if you want to sell a lot of something that is potentially addictive, all right, so say you come up with this great product that causes dependence, whether it's tobacco, alcohol, gambling, et cetera, what do? You need to minimize the risks and focus only on potential benefits. So you tell people this cannot cause any problems and it's going to cure all of your life's ills. So anytime you hear anything that along those lines, it's probably a good idea to take a step back and see if it's right or wrong. The reality is the industry standard is advertise first and apologize later. So this is what's happened with tobacco and to a large extent opioids. So let's advertise the hell out of these things. Let's put the Marlboro Man up there. Let's put opioids on every medical journal. Let's do all this stuff, cause all these problems, and then play ignorant later and eventually apologize and probably throw some money back at people that are suffering. But make hay when the sun shines, make your money, apologize later. So that's one of the things that I really concerns me with cannabinoids right now. So many non-addiction treatment clinicians do not perceive cannabis really as a problem, not even really as a nuisance. It's just there. It's accepted that everybody uses. If it has progressed to cannabis use disorder, so let's say somebody individually you're seeing is habitually using, it's interfering with their life, it's causing problems, we would certainly recommend that people seek professional help as much as someone struggling with opioids, stimulants, or alcohol. So you should take it just as seriously because it can absolutely wreck people's lives. I've treated several college students recently who it's caused serious problems with their school and their lives. There are no approved medicines yet. Sometimes we use something like N-acetylcysteine, and there's other things being developed, but a little bit in seeking help. So what's the risks really of cannabis use on the developing adolescent brain? We talked about it a little bit, but this is really what bothers me and I worry about. So my concern with marijuana is not with overdoses, but instead the psychiatric ramifications of use, especially on developing brains. So that's what really worries me when we're talking about cannabinoids. Not are people using so much that they die or something really bad happens to them acutely, medically. It's more psychiatrically, what are the ramifications? What's happening to these people as a result of heavy use, chronic use? So a little bit more on the risks of the developing brain. So two big things to know when someone's brain is basically developing from the time you're in utero to the time you're an adult is you have one, which is axonomyelination. This is basically where all the nerves in your brain are getting insulated. This is what is affected in, say, multiple sclerosis, where basically the white matter goes away. The other thing is synaptic pruning. And so this is where you get rid of excess connections in your brain. So when you're born, you have a gazillion connections. Actually, you have more connections when you're born than when you die. Okay. So our brains, when they're immature, they have way too many connections. They're imperfectly set up. They need to be pruned down and to form these normal pathways that allow us to think normally. Okay. When you repeatedly expose a brain that's developing to THC, so we're talking about exogenous THC, this will disrupt the normal process. So which is supposed to be done by what's already in our brain, anandamide and 2-AG. So when you use these external phytocannabinoids or any kind of these manufactured ones, it is going to affect this normal process. The reality is THC induces neurodegeneration at all developmental stages. And this is heavily implicated in why there's such a strong association between cannabis and the development of thought disorders. So one of the ideas of thought disorders, something like schizophrenia, is that there's basically an over-pruning state in the brain. So say you have 1 billion connections and you're trying to get down to 500 million connections. Instead of 500 million, now you're down to, say, 250 million connections. So it overdoes it in the process. I like to say instead of reefer madness, we'll talk about reefer reality. Okay. Anybody seen reefer madness? So this is just a basic, so I'm not a neuroscientist or anything, but this is my way of explaining it. So this is I couldn't find a good picture of you know hedge, beautiful hedge words, but you start out basically your brain is immature and your brain starts to through normal processes pruning away little bit by little bit, and then you're left with this nice lion at the end. Okay, so that's kind of what your brain is supposed to be doing. What happens with altered synaptic pruning? So instead of taking little pruning shears and meticulously going over the hedge, it's basically you take a chainsaw to it and you're ripping it to shreds. And now you might not be left with exactly what you had expected. Okay. The reality is, again, from the time baby's in the womb to the time your brain's basically said, okay, enough's enough, we've done enough pruning and myelination, issues will occur at all stages of that with exposure to THC. So neurogenesis, migration, synaptogenesis, programmed cell death, these are all things that are supposed to happen. The reality is that exposure to cannabinoids influences these at all levels. A little bit in terms of prenatal cannabis exposure and childhood outcomes. There's been some unfortunate studies that have shown that a lot of dispensaries, for example, will recommend THC to pregnant people with nausea, and of course, in turn, expose the fetus to it. So this was a study done a few years back of 11,500 children, 655 of which were exposed to cannabis prenatally. So prenatal exposure after maternal knowledge of pregnancy was associated with greater psychopathology. So this is where they knew that they were pregnant. Okay, so this was associated, and they continued to use associated with greater psychopathology during middle childhood, even after accounting for potentially confounding variables. So you'd see greater psychopathology, which kind of loaded term, but there's a lot to it. Prenatal cannabis exposure may increase risk for psychopathology. Consistent findings with recommendations by the Surgeon General, the U.S. Data suggests that cannabis use during pregnancy should be discouraged by clinicians and dispensaries. Unfortunately, again, we've seen dispensaries recommend it. We've seen some OB docs recommend it. The reality is that prenatal exposure can affect children downstream. A little bit more into that. This is a big study that's actually still actively being done. This is the ABCD study. Adolescent brain cognitive development. This is the big one. So prenatal cannabis exposure, PCE, associated with persisting vulnerability to broad spectrum psychopathology as children progress through early adolescence. So exposure in the womb can cause problems all throughout your teenage years. Increased psychopathology may lead to greater risk for psychiatric disorders and problematic substance use as children enter peak periods of vulnerability in later adolescence. So prenatal exposure can actually raise risk of use of other substances. Most significant differences between those exposed and those not exposed: conduct disorder, which of course, when you get into adulthood, we're talking antisocial personality disorder, and aggressive behavior, rule breaking. So these are things that you see with prenatal exposure. Okay. So is there a correlation? This is often asked between suicide and cannabis. Now, keep in mind that correlation does not necessarily imply causation. So just because two things kind of go together doesn't mean one causes the other to happen. So what about suicide and adolescent cannabis use? So this was a study that found there are associations of cannabis use in adolescents and the risk of depression, anxiety, and suicidality in young adults. So there's a lot of studies. This was the meta-analysis. The risk of depression, the odds ratio was 1.4, so it definitely raises the risk of depression. Suicidal ideation was 1.5, and this is pretty striking. Suicide attempt was 3.5. So significantly higher rates in adolescent cannabis users than in their matched adolescent non-users. So those that attempt suicide. A little bit more. This is from Colorado. It's pretty interesting. But THC was the #1 drug found in teen ages 15 through 19 who died by suicide. This was 2018. So generally speaking, when we think of suicide, whether it's adults or children, a lot of times we think alcohol. Alcohol is present and contributing. In Colorado, at least in this year, you had double the amount of, there was twice as much likelihood that you'd see marijuana there as opposed to alcohol. So around the time that they were actually rolling out more recreational use, you saw a pretty high uptick, and this was actually interestingly before COVID-19 struck. So an increase in suicides in teens, unfortunately. A little bit more association of cannabis use with self-harm and mortality among youths with mood disorders. This is a little closer to home in Ohio. And this was actually a huge analysis of 205,000 youths. I wish I was still in this age bracket, but no. So with a diagnosis of mood disorders between July 10th and December of 2017. So the idea was to just kind of follow people until the time that they left the study, there was some self-harm event or there was death. What they found was cannabis use disorder. So people that met criteria for use disorder, that it's common among adolescents and young adults with mood disorders, and it's associated with an elevated risk of self-harm, overall mortality, and death by unintentional overdose and a homicide in this already vulnerable population. That's pretty scary. A little bit more into the key and additional cannabis risks. This is just kind of general ones, but I already mentioned it, but exposure to cannabis in adolescence predicts cognitive impairment and decreased school achievement. So just by independently saying has a youth use cannabis when they're younger, you can predict if there's going to be cognitive impairment and that they're most likely going to have less achievement than an age match peer that does not engage in use. Cannabis use may cause an addictive disorder in 1 in 6 adolescents within 1 year of use and may increase the likelihood of other psychoactive drug use. So looking at it is again a gateway to other use. Cannabis use increases the likelihood of developing early onset psychosis, which makes sense with how the cannabinoid system works in our brain. So schizophrenia, suicidal behavior, depression, and actually cardiovascular problems. Driving under the influence of cannabis is hazardous. We'll talk about a little bit more. And cannabis, this is kind of a scary one, may have cross-generational epigenetic effects on the molecular level. So the idea with this is, we talked about prenatal exposure. It seems like there's actually effects where if you expose say a father rat to cannabinoids, it literally will change their genetics to the point it can be passed on to its offspring. Okay, so we're not talking about active use, baby being exposed to cannabis in the womb. We're talking about a father that's using cannabinoids where it's literally changing the sperm line. Interesting stuff. Okay, so what about the therapeutic role that cannabis may or may not serve, and what's the clinician's role in reducing harm? Okay, so again, it's not all good, it's not all bad. Like any proposed medical treatment, there are risks and potential benefits. So Marinol has been around for a long time, dronabinol. I've actually prescribed it for patients before. It's used to treat anorexia associated with weight loss in patients with AIDS. It's also used for nausea and vomiting with cancer chemotherapy. And it's actually even been considered to help with cannabis withdrawal. So if someone's coming off of high dose THC, give them a little bit of THC. Now, keep in mind that dronabinol, if anybody's ever played around with it, prescribed it, we're talking like 10 or 20 milligrams a day, not 10 or 20 grams that people get at dispensaries a day of smokable flower. Epidiolex, this is oral CBD with very little THC added, so oral CBD. This is actually approved for these intractable treatment-resistant pediatric seizure disorders, so you will see that. And there's been systematic reviews done to identify evidence for treatment of children and adolescents with epilepsy and chemotherapy-induced nausea and vomiting. So, and the Marinol more or less is used to treat adults, but there's some evidence it can help with kids. So it's not all bad. And I already mentioned that in things like pain treatment, pain doctors will use small amounts of dronabinol along with traditional medicines. Okay. I want to make it very clear to everybody, when you hear the term medical marijuana, that does not necessarily imply it's medicine, okay? It's best to say, if you hear medical marijuana, it's really synonymous with legislated marijuana. So that's the way I like to reframe it. So it's not medical necessarily, it's legislated. So the reality is there's not a lot of controls in place in terms of the quality and concentration. Unfortunately, the US, we generally, we've done this for a while, is we allow big business to dictate what goes on. So most countries actually restrict these dispensaries or these growers to just a few federally regulated companies. So for instance, if you were to go in Canada and get medical marijuana from a dispensary, you have a card or whatever, there's literally one grower in the entirety of Canada that makes all cannabis for medical use. In Europe, I believe it's two. Okay. In West Virginia alone, I don't know how many there is at this point. I know in Michigan there's hundreds. In West Virginia, I think there's at least a couple dozen. But the reality is that, you know, when you say something's medicine, the controls aren't exactly there the way you'd expect when we're talking medicine. So doctors certify patient, the way this works is really doctors certify patients for a condition. So somebody comes in, they say, I want a medical marijuana card. A doctor certifies that yes, you have PTSD, you have pain, you have seizures, you have whatever. They certify someone, but they're not actually prescribing it or managing the amount or use of cannabis. So you give somebody a card, they go to a dispensary, and they get really whatever they want. That's how it works. The reality is there's no medically accepted use of internal combustion products. So smoking, there's no medicine that is smoked to deliver medicines to the human body. So there is no other time. We don't tell people to take their aspirin and crush it up and smoke it, you know, roll it up and smoke it. There is no thing in medicine that says smoking is a good idea for anything whatsoever. Smoke is terrible for the human body. There's other things like, in ideally speaking, they say a 1-to-1 ratio of delta-9 and CBD is the least likely to cause negative psychoactive effects, but that's not what you see being actually sold in dispensaries. So typically what you see is very high potency THC products with very low levels of CBD, when what's really recommended is an even ratio between the two. So what are the concerns with cannabis use in adolescents, medical use or otherwise? So when I hear about doctors recommending it for people underage, you know, using it is really an experiment on the developing brain. And even again, our brains do not really stop fully developing until late 20s, perhaps even 30. For some people, maybe even a little longer. We'll see. Clinicians and parents especially should caution use, especially in young brains. So I don't see a place where a pediatrician should be recommending this to anybody. The riskiness of use of cannabinoids decreases or declines as brain development slows with age. So the older you are, basically, the less risky it gets to use cannabinoids. Always say be skeptical towards commercialization of cannabis. So if everybody's trying to sell it, there's probably a reason, because there's a lot of money being made. The reality is no one will freely admit to advertising the youth, but this represents the perfect demographic to get someone hooked and thus maximize one's profits. So again, if you're that business person that's trying to sell a lot of something, tell people it doesn't cause problems. It only helps. Try to get people started young and keep them on it for as long as you can. That's how you're going to maximize your profits. And the reality is we are in the midst of an arms race in terms of making the most potent products possible. All right, so how should clinicians proceed with cannabis? Very, very cautiously. Encourage people, do your own research. Don't take anyone's word for it, including mine. You know, I would say special caution with the media or any industry-driven expert lobbyist. You know, if somehow the lobbyist shows up to your, you know, your medical meeting, or, you know, brings in free lunch or whatever, your clinic, be skeptical. You know, if you want to, if someone here, let's say there's a doctor that wants to get into medical marijuana certification, just be sure that you're ethically prepared to answer to patients with resultant substance use and psychotic disorders. So if you say, okay, I've heard all this stuff and maybe I still want to do it, go this direction, start certifying people. Don't be surprised if folks start struggling with substance use or with things like schizophrenia, because it will happen. Don't let money alone be the driver to become a certifier. It's maybe a quick and easy way to make a buck, but it's ethically dubious at best. And again, I like to think of it this way. So let's say someone decides to certify. So when you're writing a certifying for someone or recommending it, so ultimately the act of doing so, ultimately clinicians who certify are recommending that a patient self-administer a largely uncontrolled, non-FDA approved, DEA Schedule 1 illegal substance to treat a variety of conditions with little to no research to ensure efficacy and safety. So that's what happens when certification happens, plain and simple. I can't think of too many other medicines we do that, again, it's sort of a blank check to take it however you want, and there's very little evidence for it, but that's what it is. This was actually from a year ago. I mentioned ASAM being part of it. This was from an ASAM lecture we had in Washington, and we had some psychiatrists from Canada come down, which was kind of neat, addiction psychiatrists, and talk about their experiences with it because medicinal goes back a long way. Just recreational is a little bit not quite as long with Canada, but they have more experience in general. So what they recommend is education to people. So what are the complications? Things like, again, psychosis, mood and anxiety disorders, memory, cognitive impairment, educating people that these are real problems that can occur with use. That there is a withdrawal, which we talked about. The onset can be fairly rapid and it can last a while. So withdrawal is a thing when you stop. Therapy is helpful. So things that we already talked about with other use disorders, but cognitive behavioral therapy, motivational interviewing, those are some things that can be helpful. And then harm reduction counseling, which I thought was kind of an interesting approach to it. So really for those that are unwilling or able to stop use. So this is a little bit in terms of harm reduction for cannabis, and I hope this is helpful for those interested. So they recommend choosing lower THC potency products, especially balanced with CBD. So if someone's going to continue to use, try to use less THC. The more THC, the higher the risk. Avoid if personal family history of psychosis, if you're pregnant or breastfeeding, or if you're younger. So strong family history of schizophrenia, probably not worth the chance. Have a baby, probably not a good idea to exposing them. If you're younger, your brain is still immature, probably a good idea to avoid it. Avoid the synthetic cannabinoids, so things like dabbing, which is concentrated THC, and also mixing with tobacco is not great. Avoid combustible products. So they recommend if someone's going to use to choose edibles over smoking. However, actually edibles will create a more intense high, and very small amounts of edibles will basically do the same thing as smoking, but it takes a while to kick in. A lot of ED visits are related to people consuming edibles, not having anything happen to them, using more edibles, and then 4 or 5 hours later getting extremely sick. So it's best not to smoke anything. If someone's going to use THC, use an edible, but be very cautious with it, very small amounts. So they're saying 2.5 milligrams, very small amounts, not 2.5 grams. Avoid deep inhalation, breath holding, occasional use. So again, looking at it more like, say, alcohol, recreational type thing, rarely, but not daily use. Talking about harm reduction. And also no driving after use because it will affect your coordination. You can get a DUI. You can wreck into a family driving under the influence. All right, lastly, what about opioids and THC? So this is a complicated subject, one largely for another day, which I promise we'll talk about at some point. The evidence is mixed, but it does not appear to lower opioid overdoses. So you'll hear things from the industry that says, oh, if marijuana became ubiquitous, you could reduce overdoses. The evidence is very mixed for that, and it seems to be actually opposite. The more marijuana, there might actually be a little bit more opioid overdoses. So you often see it advertised as a substitute drug to taking opioids. In reality, it largely serves as a companion drug. So when you hear about it talked as a substitute, think more of it in terms of companionship. So it's not a opioids or THC, it's more opioids and THC. Personally, in terms of COAT, I would not exclude someone, so patients from treatment based simply on cannabis use, but they should be encouraged towards abstinence. So I don't think it should necessarily get somebody kicked out of treatment per se, but it's definitely something you want to work toward, not just accept it as it were that it's perfectly fine, it's not causing any problems. but I wouldn't necessarily be kicking anybody out of clinic over it. And you know, this is a great topic for us to continue to discuss and echo, because I'm sure we will see more and more of it as medicalization changes, as potential recreational use changes. Stay tuned. So in conclusion, it's a complicated subject with many public health implications. Our own experiences alone should not dictate how we approach the subject as people that provide care. The system regulates normal development in the brain and homeostasis. So when we use exogenous ones, we ingest cannabinoids, it does affect our brains. It has to. The developing brains from in the womb until young adulthood are really the ones that are particularly affected by cannabis. It's clearly not all good, but it's not necessarily all bad. So there are clinical uses for it, especially when it's pure, when it's refined, when we know what's going on. My hope is that as a result of all this, we can actually have more and more good medicines that can be developed. Again, please counsel people that medical marijuana does not necessarily mean safer cannabis. And it is certainly appropriate to discuss the risks and potential benefits with anyone using or interested in using cannabis. So harm reduction does play a role in this if someone's not willing to completely be abstinent from it. So I hope this was helpful. You know, I've learned the last kind of year and a half, I've done a bit of a deep dive when it comes to THC. And if we have any questions, I'd love to take them. We got about 5 minutes ago, so I got through it pretty quick. The hypomania is still going strong, so it's great.
You did a great job. I don't know how you're functioning, but thank you so much, Dr. Houston, for that wonderful presentation. It is very interesting, and I'm curious to see what people have to say in their comments. It's a safe space, so.
Safe space. We
Safe.
shutting off the YouTube part or no?
We can always cancel that out if people weren't comfortable, obviously.
Fire away. Again, feel free to reference the slides. We're going to be doing for those going to ATI, I think I'm going to be doing something similar on cannabinoids. So if you have questions, then it'll probably look a little bit like this lecture, and hopefully I'll be a little bit more awake for it. So.
I just wanted to say thank you, Jeremy. It was a good job, even if you hadn't slept, and focusing on the adolescent brain is very helpful. Thank you.
Yeah, I think when we're talking to people that want to continue to use, we can all agree sort of that we don't want to see our kids struggle. So that's a good place to reach people. You know, if you're going to use, don't use around your kids. Don't encourage them to use. It's certainly those are the risky times. So I think we can sometimes with people with that too, as well.